So good afternoon. I know this is the last session, so we'll be short and try to stay on time. We're standing between you and your dinner plan, so here we are. It is active. Please save the questions for the very end. My name is Chen from University of Florida. You guys all know Dr. Driscoll. We have a very exciting list of panelists. Dr. Blevins from Stanford will give us a video case of facial nerve decompression for Marcus and Rothenthal syndrome. Dr. Dinh from University of Miami will describe a case of facial nerve transposition for jugular foramen tumor. And Dr. Roland from NYU will describe a complex cholesteatoma involving the IAC. And finally, Dr. Haynes will give us a case of facial nerve management in chronic ear diseases. Dr. Blevins.
Great. Well, thank you, Dr. Chen, and thank you, Dr. Driscoll. Appreciate the opportunity to speak here. So I'm going to be talking about facial nerve decompression for presumed Marcus and Rosenthal syndrome. I have no relevant disclosures to the management of this case. The case I'll discuss is a 45-year-old woman who had about 13 episodes of right-sided episodic facial palsy. Overall, it was progressive. Some of these episodes had been complete. Some of them had been partial. Some of them improved with steroids. She did have some occasional swelling of her lips and tongue and no known family history. When I saw her, she was grade 3 out of 6, normal otoscopic findings, normal facial findings other than the facial weakness, negative MRI, and we got a CT scan as well. Her hearing was normal on that side as well. This is the reconstruction of the CT that we'll be using to look at some of the anatomy during the video. She did have the finding of a narrowed segment of the second genu on the ipsilateral side, and with that, we offered her both a middle fossa and a transmastoid facial nerve decompression, and I'll really only be talking about the middle fossa component of this. And in answer to Dr. Driscoll's question about whether I stand or sit, I sit down. If I were operating standing up to do this, I would be kicked out of the operating room for good reason. So this is definitely a sitting case for me. So this is with her in operative position. We made this incision on the temporal for the temporal craniotomy. Craniotomy is being designed to be just anterior to the external auditory canal. I like to actually see the external auditory canal and the root of the zygoma. That helps me position the craniotomy appropriately. The temporalis muscle has been reflected anteriorly. I like to leave a little corner of the mastoid covered posteriorly. We really don't need to go all the way down to the floor in that area, and there's some air cells that are better left just covered. This is after the craniotomy bone flap has been removed. I like to take the floor down to the middle fossa floor. I like to use the sharp end of a caudal to elevate the middle fossa dura. Always have some bleeding anteriorly and posteriorly, a little bit of hemostatic agents and some cotinoids help with that. Here's the GSPN, an important landmark for us. This is her anatomy shown on the CT scan. So the internal auditory canal is going to be here. GSPN is what we see here. Arcuate eminence is posteriorly. And there's sort of a bluish area out here where the thin bone over the epitympanum is located. This is my neuronavigation system. It's pretty inexpensive. So a plastic ruler, I like to cut it. I like to hold it with a snap. And I always measure these distances of whatever I'm trying to get to and write it on the board in the OR. And I can get about millimeter accuracy on that. So I think that's pretty good for a $2.50 neuronavigation device. I also will use the PRAS probe stimulator. I like to use this a lot in my facial nerve cases. It gives me the opportunity to move tissue as well as just stimulate. And we do see some stimulation over the geniculate ganglion. Now we're going to start the decompression. In finding the labyrinthine segment, I really like to start in the mid portion of the IAC here. There's a lot of real estate in this area where there's nothing to hit. The cochlea is right up against the GSPN here. This is a 3 mm burr. I've left about a burr and a half length away from the GSPN. This is identifying the labyrinthine segment as it comes off the top of the IAC. The stimulator can also be used to confirm that. And you have to remember that this labyrinthine segment is going to be going from deep to more superficial as you go from medial to lateral. So keep that in mind as you drill laterally. There's not a lot of room on either side of the labyrinthine segment, so I've switched to a 2 mm diamond here. The cochlea, again, is going to be right in this area. The labyrinth is going to be posteriorly. We do have more space between the labyrinthine segment and the labyrinth than we do between the labyrinthine segment and the cochlea, so I will tend to cheat a little bit posteriorly here rather than trying to drill any farther anteriorly. Once I've traced that out from where it takes off from the IAC to the geniculate, I'll switch. This is a 1 mm diamond burr, taking off the last little bits of bone. Again, keep in mind just how close we are to the cochlea here. There's more room posteriorly. You can kind of see the way that I've drilled in that area. And then I'll just follow the IAC on the labyrinthine segment, dura and epineurium. I'm okay with leaving little bits of flecks of bone. I use this little joint knife. This is my favorite instrument. Colin was asking about what instruments we like to use. I use this extensively for facial nerve dissection, removing little bits of tumor, cholesteatoma off of the facial nerve. I also decompress the geniculate ganglion. It's always hard to know just how much to do here, but I got a nice, soft, continuous epineurium from the IAC out to the geniculate ganglion. And so this is just the superimposed anatomy as well over the area that we have done our dissection. And yes, because of the way I made that incision, I was able to go post-auricularly, just did a mastoidectomy, facial recess, and decompress the facial nerve also where that area of narrowing was also found, just to give her a complete decompression. Everything went well post-operatively. Interestingly, she pointed out to us that her face was moving better before she left, and I have to agree with her. It was pretty subtle, but she got downgraded from a 3 to a 2, which we were all very happy about. I don't have any long-term follow-up on her, unfortunately, but she was certainly doing well when I saw her at the end. Thank you.
Can you turn on the audio? I'd like to thank the ANS and Dr. Driscoll and Dr. Chen for this opportunity. I'll be talking about facial nerve transposition for jugular foramen tumor. A little bit sick, so I added the audio to the video.
This is a right secretory jugular paraganglioma resected via transotic approach with facial nerve transposition, parotidectomy, and neck dissection. The internal carotid artery was coil embolized. The patient is deaf on the affected side with cranial nerves 9, 10, 11, and 12 palsies. She has frequent nausea and vomiting and uncontrolled hypertension with systolic pressures greater than 200. We created a C-shaped incision, transected the ear canal, and raised a temporal parietal fascia flap. We performed a parotidectomy followed by a neck dissection and removed the styloid process to access the jugular foramen. We divided the posterior belly of the digastric, dissected cranial nerve 7 and the lower cranial nerves. We ligated the internal carotid artery and internal jugular vein and dissected cranial nerve 9. We drilled a mastoidectomy and decompressed the tegmen, the sigmoid sinus, and the retrosigmoid dura. We identified the incus and the lateral semicircular canal. We then identified the mastoid segment of the facial nerve and traced it down to the stylomastoid foramen. We removed the incus and debulked the tumor from the ear canal. We then elevated a tympanomiatal flap and resected the eardrum and identified the chorda tympani. We then drilled the posterior bony ear canal for exposure. We removed the malleus and then drilled the hypotympanic bone for exposure and dissected the tumor to expose the cochlea and the tympanic facial nerve. We drilled into, then through the cochlea to gain access to the petrous apex and dissect the petrous carotid artery. We skeletonized and decompressed the mastoid segment of the facial nerve and then removed the mastoid tip to gain access to the stylomastoid foramen. We incised the periosteum at the stylomastoid foramen and dissected the facial nerve through the digastric muscle fibers. We then removed the styloid process and begin to mobilize the facial nerve at the stylomastoid foramen, being careful to leave a cuff of soft tissue to aid in the transposition. We then mobilize the mastoid segment of the facial nerve, stopping at the second genu in order to preserve the blood supply to the facial nerve. We then transpose the facial nerve anteriorly, securing it to the soft tissue around the TMJ. We drill a labyrinthectomy, being careful to preserve a bridge of bone to protect the tympanic segment of the facial nerve and its blood supply. We then skeletonize and decompress the internal auditory canal contents. We externally compress the sigmoid sinus using Surgicel. Through a variety of methods, we remove the occipital bone and decompress the lateral and posterior aspects of the jugular foramen. We then ligate the sigmoid sinus using 2O silk suture. We then incise the internal jugular vein and inject hemostatic agent to control bleeding from the inferior petrosal sinus. We also incise the sigmoid sinus and inject hemostatic agent and open up the jugular bulb to remove the tumor contents. We then debulk the tumor. After removing the internal jugular vein, we transect the lower cranial nerves at the jugular foramen. We then incise the posterior cranial fossa dura to identify the brainstem and the root entry zone of cranial nerve 8 and then 7. We then debulk the intracranial tumor and identify and transect the lower cranial nerves at its root entry zone at the brainstem. We then peel tumor from cranial nerve 7 and 8 and continue to dissect the tumor towards the petrous apex. We then resect tumor from the petrous apex and around the petrous carotid artery. We stimulated the facial nerve at the root entry zone and there were good responses. We sutured our dura to create a tent for our reconstruction. We plugged our eustachian tube with temporalis fascia, Surgicel, and bone wax. We released our facial nerve and placed temporalis fascia over the eustachian tube and positioned our temporal parietal fascia flap around the facial nerve and over the eustachian tube. We then drilled 1 mm holes in the posterior ledge of bone to tack our temporal parietal fascia flap to the mastoid bone. We obliterate the mastoid using abdominal fat and create a watertight closure using dermal fat fascia. We close the incision and the patient wakes up with a House-Brackman grade 2 that declines over 2 days to a House-Brackman grade 5. She was started on acyclovir for Bell's palsy and quickly recovered to a House-Brackman 2 the next day. At 6 months, she's asymptomatic and has normal facial function.
Thank you.
This is a right
The questions for me to try to answer was what approach for this lesion, and then how do I close the case, and then follow up. So this is a complex tumor of the IAC. I'd like to acknowledge my current fellow, Michael and Ariana, one of our senior residents. This was on her Bellevue rotation as the otologist. This is a case from our public hospital. So it's a 46-year-old female with an 18-month history of right facial paresis. She had been treated for Bell's palsy. She came in at about a grade 4 to 5. Everything else was intact, and she had a mixed hearing loss on that side. She had a retraction pocket. That's her mixed hearing loss. On imaging, you can see this lesion all around the labyrinth and the cochlea, the petrous apex. Very similar to what Colin showed earlier, I think. It's into the IAC, it's also into the cochlea right there. So we decided to do, after some discussion, a right translabyrinthine approach for resection, expose the facial nerve, the geniculum, and closed off with abdominal fat and blind sac and plug the AC. At the conclusion, her facial nerve still had motion. She somewhat lost a follow-up from, which is not atypical for some of our Bellevue patients. And this is just exposing the air and dissecting it. Dura was exposed. Here's the horizontal facial nerve. Geniculum's under there, and then the IAC. Peeling it off the dura. We don't have Mesna at Bellevue. If someone asked me a Mesna question, would Mesna work for epidermoids, intracranial epidermoids? And the answer is we don't know. There have been some reports in the neurosurgical literature of using it for other lesions. So we're actually in the middle of a guinea pig study to see if there's any intracranial toxicity. Here's a horizontal facial in the geniculum. You can see it under the nerve, and it's going into the IAC. The cochlea is just under there. Oh, did I do that? Game plan was from the beginning was she's probably going to lose hearing and that we would offer her a cochlear implant. Yep. Yeah, it's cholesteatoma all under here, underneath the facial here. Granulation tissue around it. I didn't show it here, but after this removal, then we'd take a diamond burr, and everywhere cholesteatoma was in touch with bone, we would burr it a little bit. Under the labyrinthine, under the horizontal facial as well. A little trick I like for eustachian tubes is I take the incus, cut off a long process, and use the short process as a spear, put it in place over the muscle and lock it, and it makes a nice firm fit. So we swung the temporalis, the tensor muscle down into the eustachian tube and then did that. You'll see that technique later. This is where it gets into the cochlea, medial to the facial. Just to look around without having to lift the geniculum up, we looked under the geniculum, it looked pretty good. Did a second layer for the blind sac closure. Give it an extra layer for. There's the tensor muscle going down the eustachian tube, and then there's our little incus spear, which works really nicely. push pretty firmly. Remember, the carotid's inferiorly. It locks it into place. Thank you.
Well, thank you. When Colin asked me to participate in this panel, I said, Colin, I don't really take videos much anymore. And he said, well, that's why I'm letting you know a whole month ahead of time. And so I looked at the schedule, and there were some good cases on there, but I settled on, and I kind of imagined showing these giant tumors being peeled off the facial nerve, but I settled on a case where I'm not peeling anything off the facial nerve. But I think it'll be interesting, more so on the decision-making. May have to figure out how to start and stop this. And I'd like to thank Nadine Ibrahim. She made these slides for me. She didn't put her own name on there, though, but she did this whole video. So there's a case that I think there's cases that influence all of us. As Colin said on the last panel, we all have similar training, similar caseloads, but it's the cases single cases and those responses to patients that kind of influence what you do. And when Mike Glasscock retired, he said, I'm giving you this case. And he retired in 1997. And he goes, this person's going to require a lot of recurrent surgery, and I want you to get to know him. And it was a patient who had a petroclival cholesteatoma, petrous apex cholesteatoma. And he'd had surgery in another state. Mike had adhered to him. And he had this nice transcochlear, translab, facial nerve transposed kind of case. But the problem was that the cholesteatoma had recurred deep on the carotid, and that complicated things significantly, as you can imagine. Here's the case, what it looks like now. Nothing there, no landmarks, cholesteatoma everywhere. And you have to dissect through this. This isn't the video's on the next patient, but this kind of influenced what I did on the next case. It's the only case, I think, where I'm dissecting with a nerve stimulator, because you can't see the nerve. The nerve's in here somewhere. And it moves. When you go in and debulk this case, there's cholesteatoma you take out, and then the next time you go back in, the nerve's in a different spot. So you're like trying to map this nerve out. And you can't even see it because it's circumferentially involved with cholesteatoma and the matrix, so it looks like cholesteatoma. So it's quite difficult. I don't know if any of you have a case similar to this, but he comes in. The initial case was good. He had a house 2 after a big operation like that. He's at a baseline 3, and he comes in when he's like a 5.9 to get this sort of redone. And each time I'm worried he's just going to wake up with a complete paralysis. And he probably will one day. The only place we really know where the nerve is at the stylomastoid foramen in the IEC. And it changes. Again, it's, you can see here, there's just no landmarks. The only landmark we have is this IEC, and the rest of it, it moves. So with this kind of knowledge early in your career, we've all seen other cases like this, and this is a patient similar who had a canal wall down when she was a child, and likely a congenital cholesteatoma. And the canal wall down cavity looked great for years, and she came in with some facial twitching, and this cholesteatoma here had been growing for 3.5 decades, right? Involving the dura, involving the carotid, involving the cochlea, and the facial twitching was in the IEC. So the concept of trying to completely resect this cholesteatoma was formidable, right? Because you may win on the dura, and lose on the IEC or may win on the carotid. And so, you know, the chances of this recurrent was so high that you're thinking, how can I alleviate her symptoms? She came in not requesting to have this cholesteatoma completely resected. She came in asking to not have this progressive weakness and twitching. So I wanted this nerve to stay in the position that I know it is, where we all know it is, right? In the IEC, covered in bone, where I know each time I was playing the long game, knowing that I'm likely going to have to come back. And I didn't do the big operation, but I did a smaller operation here to decompress this and successfully decompress the cholesteatoma without trying to pick this off of her dura, without trying to pick this off of her carotid and, of course, her IAC, where the nerve's involved. Now, she had a canal wall down cavity. It's a nice cavity. You can't even see hardly the recurrence. There's the facial nerve. Here's the tympanic membrane. We elevate this. We've left bone over here on the tympanic segment and the mastoid segment to make sure we can do this. We lift the tympanic membrane up, of course. And you can see the cholesteatoma in this infracochlear air cell tract. That's probably where this started and progressed medially to involve her clivus and everything you saw there. So we we're able to drill a lot of the tympanic bone here and get access to this under the cochlea. I even left the cochlea in place too because I like that landmark. And then we decompress this cholesteatoma on a regular basis, anywhere from 2 to 4 years, without any attempt to try to remove completely and resect this cholesteatoma. You can look at the dura, and I think Walt said this last time, that cholesteatomas are different, right? There's some of them that are like candle wax and some that are spray painted, and some grow and some don't fast, right? And you just don't know, but my first move on these is to try to see if, and assume that we're going to be coming back and make sure that you can find these landmarks. And she's doing very well. She has normal facial function. She has no pain. She has no issues. And we sometimes will get CSF leak, and it gives you an idea that you're really not going to really resect this cholesteatoma from this dura without requiring a huge surgery. So the take home is play the long game, keep the nerve encased in bone, don't try to move it, and be ready to know that you're likely going to come back for serial decompressions of a case like this. And the goal really is to keep her from having a facial paralysis. That's all she wants. We've considered doing this under local. She actually does not mind having surgery every 2 to 4 years. She doesn't want to have a facial paralysis. She comes back sometimes asking, for a sooner surgery to prevent being where she was when she came in. So, thank you.
Thank you all for the excellent panel. Thank you for your time, and thank you, Dr. Driscoll, for organizing this. We're open for any questions.
No, it's too late.